Welcome, everyone, to ERMP and Beyond, where the heartbeat of clinical medicine resonates with every case we explore. We invite you to embark on a journey through the intricate world of medical puzzles. Together, we'll dissect, analyze, and solve the enigma that awaits us. Prepare to be challenged, enlightened, and inspired as we delve into the essence of today's medical marvel. Let's begin our quest for knowledge and understanding without further ado.
A 37-year-old male patient came with a complaint of recurrent right lower quadrant crampy abdominal pain, diarrhea, fever, weight loss, and vomiting. He has aphthous ulcer and mild abdominal tenderness. The white blood cell count is 15 thousandths per microliter, and hematocrit is 30%. Sigmoidoscopy of the anus and rectum is normal. What is the most likely diagnosis for this patient? A. Diverticulitis. B. Crohn's disease. C. Ulcerative colitis. D. Gastrointestinal tuberculosis. Welcome back again. Today, we're going to see a complex topic that affects millions worldwide, the inflammatory bowel disease. Specifically, we'll be comparing and contrasting two major forms of inflammatory bowel diseases, the ulcerative colitis and the Crohn's disease. While they share some commonalities, their differences are crucial in understanding how they affect individuals and how they are managed medically. Let's start with what ulcerative colitis and Crohn's disease have in common. Both of these conditions present with a range of symptoms that can significantly impact a person's quality of life. Individuals with either ulcerative colitis or Crohn's disease may experience abdominal pain, persistent diarrhea, unintended weight loss, and a general feeling of fatigue. These symptoms can be debilitating and often require medical intervention to manage. Another similarity is the chronic inflammation that characterizes both ulcerative colitis and Crohn's disease. This inflammation occurs in the gastrointestinal tract, which includes the mouth, esophagus, stomach, small intestine, and large intestine. It's this inflammation that leads to many of the symptoms associated with inflammatory bowel diseases. Moreover, ulcerative colitis and Crohn's disease can manifest beyond the confines of the GI tract. This is what we refer to as extraintestinal manifestations. Patients may experience joint pain, which can range from mild discomfort to severe arthritis. Skin rashes and eye inflammation are also common, indicating that inflammatory bowel diseases is not just a local issue within the digestive system, but a systemic one affecting multiple body systems. Now, let's talk about how these conditions are diagnosed and treated, as there are many parallels here as well. Diagnosis typically involves a combination of endoscopic procedures, imaging studies like CT scans or MRIs, and biopsies of the intestinal lining. When it comes to treatment, both ulcerative colitis and Crohn's disease are managed with a variety of medications aimed at reducing inflammation and controlling symptoms. Anti-inflammatory drugs are often the first line of treatment, followed by immunosuppressants that help modulate the immune system's response. In more severe cases, biologic therapies, which are targeted treatments that interfere with specific pathways of inflammation, may be used. Despite these similarities, it's important to note the distinct differences between ulcerative colitis and Crohn's disease. Let's start with ulcerative colitis. Ulcerative colitis is confined to the colon and rectum, and it always involves the rectum. The inflammation in ulcerative colitis is continuous, beginning at the rectum and spreading proximally in a uniform pattern. It only affects the innermost lining of the colon, known as the mucosa. Symptoms typically include bloody diarrhea and pain in the lower left abdomen. During a colonoscopy, the colon wall appears thinned, and the ulcers are superficial. Ulcerative colitis presents a higher risk of colon cancer, toxic megacolon, and primary sclerosing cholangitis. Now, let's turn on to Crohn's disease. Crohn's disease can impact any part of the gastrointestinal tract, from the mouth to the anus. However, it most commonly affects the end of the small intestine and the beginning of the colon, aka ileocecal region. Interestingly, the rectum may be spared. The pattern of inflammation in Crohn's disease is patchy, with inflamed areas interspersed with healthy tissue, known as skip lesions. Crohn's disease inflammation extends through all layers of the bowel wall, which can lead to deeper ulcers and the formation of fistulas. Symptoms often include pain in the lower right abdomen, and unlike ulcerative colitis, bleeding is less common. Crohn's disease also presents a higher risk of colon cancer, toxic megacolon, and primary sclerosing cholangitis during a colonoscopy. The risk of complications like strictures, fistulas, and abscesses is significant, and smoking can exacerbate the condition. On colonoscopy, the appearance of the colon in Crohn's disease is distinctive, with a cobblestone pattern due to deep ulcers and thickened walls. Understanding these differences is crucial for diagnosis and treatment. While they may share some symptoms and risks, the location, pattern, and depth of inflammation, as well as the overall appearance, set them apart. Now let's back our patient. The patient's symptoms of recurrent right lower quadrant abdominal pain, diarrhea, fever, weight loss, vomiting, aphthous ulcers, and elevated white blood cell count are suggestive of an inflammatory process. The normal sigmoidoscopy rules out distal colonic involvement, which is common in ulcerative colitis, making option C less likely. Option A, diverticulitis, typically presents with left lower quadrant pain and is less likely to cause systemic symptoms such as fever and weight loss. It is also more common in older patients, making it less likely in a 37-year-old. Option B, Crohn's disease, is a chronic inflammatory bowel disease that can affect any part of the gastrointestinal tract, often with a predilection for the terminal ileum, which is located in the right lower quadrant. This can lead to the symptoms described, and the presence of aphthous ulcers is also consistent with Crohn's disease, as it can cause similar lesions in the mouth. Option D, gastrointestinal tuberculosis, could present with systemic symptoms like fever and weight loss, and abdominal pain, but it is less likely to present with the specific pattern of crampy right lower quadrant pain and would typically show more extensive involvement on endoscopic examination. Therefore, based on the information provided, option B, Crohn's disease, is the most likely diagnosis. It accounts for the patient's systemic symptoms, the location of the pain, the presence of aphthous ulcers, and the lack of findings on sigmoidoscopy, which is consistent with Crohn's disease's ability to affect the gastrointestinal tract in a patchy and discontinuous pattern. The elevated white blood cell count and decreased hematocrit level further support the diagnosis of an inflammatory condition like Crohn's disease. It is important to confirm the diagnosis with further imaging, such as a CT scan or MRI, and possibly with a biopsy obtained via colonoscopy to examine the full extent of the colon and the terminal ileum. Management would involve anti-inflammatory medications, immune system suppressors, and possibly surgery if there is obstruction or complications. Patient education on the chronic nature of the disease and the importance of regular follow-up is also crucial. As we conclude today's topic, I want to express my heartfelt gratitude for your participation. Discussing inflammatory bowel disease has been an enlightening experience, and I hope it has been equally informative for you. Your engagement is crucial, so please, subscribe to stay updated on future sessions. Your likes and comments not only enrich our case discussions, but also help us reach a broader audience through the YouTube algorithm. Thank you once again for your active involvement in today's journey of knowledge.